Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, welcome back to the Health Upgrade Podcast. This is Dr. Habib. I'm joined by my co-host, JP. Great to see you, JP.
Great to see you too.
And we have a wonderful guest today, a friend of mine, a wonderful medical doctor who is, in my opinion, one of the world's authorities in chronic pain and approaching chronic pain from a holistic standpoint. He practices out of Philadelphia at Ether Medicine. Just a wonderful gentleman, and I'm really excited to have him on, Dr. Asare Christian. This episode of the Health Upgrade Podcast is brought to you by Truvaga. Have you been looking for a simple way to feel calmer, think clearer, and sleep better? Imagine achieving this with just 2 minutes a day. I'm excited to introduce you to Truvaga, a handheld device that supports your nervous system through gentle vagus nerve stimulation. As a doctor specializing in functional health and wellness, I've seen firsthand how Truvaga has accelerated healing in my clients. I've used this device to help people with a range of issues, from sleep disturbances and heart palpitations to digestive dysfunction, nervous system imbalances, and mental wellness concerns. The results have honestly been remarkable. Truvaga is designed to catalyze and accelerate the shift in your body from fight or flight to rest, digest, and recover mode, helping you manage stress, maintain mental clarity, and unwind more easily. It's not just theory. I've witnessed its positive impact on real people facing real health challenges. The best part? Truvaga fits seamlessly into your routine. No need to carve out hours for wellness. Just 2 minutes a day can make a difference. It's a small investment of time for potentially significant benefits in how you feel and function each day. If you're curious to experience Truvaga for yourself, visit truvaga.com/upgrade. You can save $30 on your device by using the code UPGRADE30 at checkout. Remember, that's truvaga.com, truvaga.com/upgrade. It might just be the first step towards a calmer, clearer you, just as it has been for many of my clients. How are you, Asare?
I am well. I am honored to be here and really appreciate our friendship going back maybe a year or two ago when we met and came to your lectures. Love what you were doing. And since then, you've been great connecting, and here we are. So excited to be here.
Likewise, because when we met, you did a talk very similar to the one that I just heard from you in New York. Slightly different topic, but it was very much on the idea of chronic pain. And I would love to kind of share, because chronic pain is becoming far more prevalent in terms of being diagnosed, how many people are dealing with it, and the effect that it's having on our lives, our productivity. And I'd love to kind of dig into some of the stats, some of the data, what chronic pain really is. But there seemed to be a really important story that brought you into trying to uncover a better way to address chronic pain. I'd love for you to share that story.
Yeah, so thanks for that opportunity. And just a bit background, as you said, chronic pain. In fact, I did not even want to go into pain when I was finishing residency and all of those things. So I went to get a public health degree. And during my public health, I became aware of one of the biggest public health problem we have in the US and in the world is pain. As it turns out, there's more Americans with pain than diabetes, heart disease, and cancer combined. And it also costs a lot of money because people that have cancer have pain. People that have cardiovascular disease have pain, and that costs a lot of money. And the problem we have is that pain is poorly treated, it's poorly understood. So we have all of these individuals that are going through treatment or specific disease states that leads to chronic pain. And we'll go to the definition of chronic pain. And then more specifically to my experience of really trying to get to a different approach of treating chronic pain is, I did pain management for individuals with spinal cord injury, brain injury, neurogenic pain for some time. And then I opened my own practice 3 years ago, Ether Medicine. And the inception for this practice was that, and which is something I intuitively know, when people are healthy, pain gets better because patients don't even understand pain, right? Pain is a symptom. What is driving the pain is what we need to get to. And it's a function of health. So when people are healthy, pain gets better. So the whole idea was I wanted to figure out how to use health as a way to solve pain. And the interesting thing is that, even though I've been a doctor for 10 years, I did not know how to solve health. I knew how to read MRIs. I knew how to do, diagnostic block. I can do injections. I can do all of those things. But the fundamentals of getting people healthy, I did lack. So Throughout my initial start of this practice, I had a patient coming, young patient in their 30s, have had this chronic pain. Nobody could really figure it out. She came to see me. I knew what I knew, but back then I just did my gabapentin and whatever I have to try to help her out. It did not help. And she went to all of these places trying to get help in America, right? We had advanced health system. We have great health systems in this area here, but nobody could solve her pain. And eventually she took her life. So this was a very sad case that has kind of stuck with me. This was a young person who did not have any other medical issues except pain. And in fact, chronic pain is now considered a disease. And we'll get into, some of the things that goes on there. So it really kind of pushed even me a little bit more further to say, okay, I need to really figure out how we solve this and how do we solve this in an effective way, because I've been taught and I was trained well. I went to Hopkins, I went to Harvard, all of those things, right? So, I knew how to do those things, but yet there are so many people just like her who are still struggling in pain because we're not looking at fundamentally how to solve health as a way to solve pain. So, a sad story, but it's really kind of stuck with me. And my goal is to really try to figure out how to make sure that people are aware of this and find better ways to solving pain for patients, because there are solutions.
I love that. And the fact that you've tried to uncover that there had to be a better way, and it has to do with enabling the feeling of being healthy, of truly experiencing what health means. I'd love to get a sense of, at this point, having gone through all of the journey that you have so far, what does health mean to you? What is true health?
Yeah, so that's a great question. And I've gone through different conferences, and recently the conference we went to talking about health. So I think for me, my background is in physical medicine and rehabilitation. So physical medicine and rehab, we especially that don't focus on like a specific organ system, like the cardiologist is focusing on the heart or GI doctor or whatever. So we focus on function. So irrespective of whatever organ disease, function. If you can't get up in the morning, go to the bathroom, wash yourself, all of this. And so I think for me, intuitively, health is relating to optimal functioning, okay? Optimal functioning in the sense of metabolic health, cardiovascular health, immune health. So all of those things. And then relating to that idea of function is also resilience, which I think when we went to the conference, Dr. Paul Matter and some others were talking about. So I think really being able to optimally function is how I define health. And how we get there can take multiple ways. And it's all a function of looking at the whole system to get there.
I love that, because that it really is what functional medicine means.
Yes.
And if you're not functioning optimally in any particular way, it can lead to any host of conditions. That's a great way to put it. So great one there.
We talk a lot on our podcast about the different things that underpin good health. And, when you see people in pain and recognize that their pain is a function of them not being in good health, it could be any one of those pillars that is failing. And we talk about the pillars being your immune system, your cellular energy, your ability, your mitochondria, your ability to produce ATP, which is really the currency of all chemical reactions in the body, and then your interactions with your environment. And since our bodies are covered in skin and airways and digestive tract are all infused with bacteria and other single cell organisms and even viruses, that our ability to interface with that world in a healthy way that keeps us healthy is important. And the final piece is, of course, within the cell, the ability to understand whether the proper nutrients are there to grow or not grow properly. But pain is one of the cardinal signs of inflammation. Do you see pain coming from other sources other than inflammation? It's a loaded question because I know the answer is yes, but I'm just wanting to dig into what some of those other causes of pain that might not be immediately associated with inflammation that you see.
Absolutely. And I love the fact of talking about those pillars of health. And in fact, in my clinic here, I have 4 rooms. And, we'll get back into the cellular stuff. But the first room is labeled meditation. The second room is nutrition. The third room is sleep, and then exercise. So these fundamental things that people need to do, right? Because those are the things that are a function of producing health. And then to the very thing you talk specifically about pain, looking at immune activity influencing pain. So yes, inflammation can create pain. But one of the things that I also want to kind of push out there is that inflammation does not equate to pain. right? So inflammation is a cascade that is in response to a certain type of trauma, stress, whatever it is. And in fact, a lot of times inflammation is there to correct a problem, right? You have cytokine activations and all of those things that are activated. And as part of that, whatever cascade that the body is trying to heal, then it can also signal specific nerve, C fibers, and that nerve signal will take that information and it goes through the spinal cord and it goes all the way to the brain. And there's all this, modulations that are taking place as it goes from the spinal cord to the brain. So until that signal gets to the brain, we don't have pain. So the first point is that inflammation does not equal to pain. And in fact, when you asked about other things that can cause pain, so because the signal is going to the brain, and the brain is a master place of interpretation. If people have had previous history of trauma, PTSD, other type of trauma that makes their nervous system hyperactive, a small signal coming in is blown up as a big source of pain. And in fact, in chronic pain, there's all of these changes that happens where even the pain itself is coming from the brain. The brain can create it. So there's something called neuroplasticity, where the brain has learned the pain itself. So for example, there's individuals who've had chronic back pain where we've done studies where we put them in an MRI machine, they're laying flat, and we just tell them to close their eyes. Imagine bending down to pick a piece of paper. Just thinking about that alone creates pain. And I think that's an important concept for individuals to understand, because when it comes to chronic pain, it's not just what's happening in the periphery. It's all the other things that are going on. And as you talk about the cellular energy, you have microglia, you have astrocytes, you have all of these cells that are immune cells that are modulating that signal. And if they don't have good energy, if they're not signaling well, that will influence pain. And whereas even the ability to kind of do the work very well is influenced by the gut. So microbiome will influence central sensitization and all of these processes. So the point is that, as you said, it's not just inflammation. There's biomechanic deficits that can happen when people have chronic pain. Muscles are weak, and that can create that. There is neuroinflammation that can create pain. There is epigenetic changes. Your own brain has its own endogenous opioids that makes to control pain, where it can become dysregulated, whether it's a function of a cell. So if the cells are not working well. So I like this idea of you talking about mitochondria, because it's all about energy. It's all about metabolism. And if those places, these things are not working well, that will influence how pain is created. So many other things can create pain or even make the experience of pain worse. Anxiety, stress, other factors. So it's not just inflammation, and inflammation is not equals to pain. Inflammation can create pain.
I love this topic because it shows how the central nervous system is where we experience everything. When you bang your knee into a table, you don't feel the pain because the table was there. You feel the pain because your brain tells you that that's the proper interpretation of banging your knee into the table. And that can be altered. And I find it fascinating because I know a personal story, or I have a personal friend who experienced something when she was a child that was very traumatic, but she had no context into which to put it, the experience. And as a result, experienced no pain. And it's a pretty dramatic story. I'm going to tell you what it is. She was 6 years old, and she grew up in a relatively less than affluent circumstances. And she was sitting on the stoop of her apartment building, and she saw what she thought was a cap gun, okay? And she picked it up. She was 6 years old, and the gun went off, made a loud noise, and she said that she felt as if something like a rock had fallen off the ledge of the apartment building and had hit her in the leg. And it was not until a few minutes later that she noticed that there was a significant amount of blood on the ground near her, that she realized that she had actually been shot by a 9mm in the leg. And she had no pain. And the reason, as I understand it, and you're going to help us understand together, is that all of the nerve signals were sending the message up to the brain, this is a big problem, you've got an issue here. And yet the brain had no memories or context into which to put those signals to attach pain to it. And as a result, she didn't experience pain. And we actually hear about this sort of thing quite a bit. People get shot and they don't know it. And then we always sort of write it off as it's an adrenaline burst, et cetera. But many times it's simply a function of the fact that the brain has no context into which to process that information until it has more information that suddenly later on, yes, it becomes painful. Talk about how that occurs. because I want to take it at some point into the direction of how can we reverse that? And what happens if the opposite is true, where the context for everything is driving pain?
That is a great question. And I'm glad that you bring this up, because I think this is one of the major concepts that individuals in chronic pain have to understand. Okay. As you said, pain is influenced by various degree of your biology, your psychology, your social environment. So even pain is cultural. Even the house you grew up in, if you were made not to think about pain, tough it up, whatever, your pain experience is different. Okay. Culturally, I'm from Ghana. I grew up in Ghana, and I always talk about this. The fact that, in America, we make up 4% of the world's population, yet America uses 80% of the world's opioid. Okay. So do we have more pain than anybody else? So even the culture influences pain. But coming to the part of the brain, which is very fascinating, because the brain has to do so many things. And first of all, even stepping back, the reason for pain is that pain is a protective mechanism. Pain is there to kind of warn us that something is up and we have to, pay attention to it. So when we have pain, there is two signals, two pathways that creates pain in the brain. So you have a pathway that sends sensory information, so you can tell, okay, like the example you gave, it hurts, it's painful, okay? And then there's also another pathway called the spinothalamic pathway. So there's a spinothalamic, which is the pain, and then media reticular, which send emotional. So there's always an emotional component to pain. So pain has a sensory and emotional component. And the reason why we have the emotional component is that emotion crystallizes memory. Emotions helps us to remember because it's a protective mechanism. Once you step on something hard, you remember not to do that, right? The idea of a snake or something, because that emotional thing creates a way for you to be crystallized to say, no, this is not what I need to do, okay? So in the context of PTSD, the same thing happened. And sometimes the emotion can be so strong that it will overshadow the sensory component for a minute, and then things will just catch up, okay? So for example, when like a gun goes off or something and you shot yourself, there is other things that your body is trying to make sense of, and the brain has to do all of those work. So survival, pain, which one is more important? Survival, okay? So people have had traumatic events where they've lost a limb and they can run with a limb that's fractured and broken because they were being chased. So very important to understand that the brain put context to the pain experience. So people's pain experience will be worse if, for example, they lost somebody in their family. I'll have patients come to me and they go, my back is hurting. I have no idea why this has become an issue for me. Can we get an MRI? And then I go and I say, what's been happening? Oh, I just lost my daughter. Of course, that's going to increase your pain experience, okay? And then there's also a connection between pain, cognition, and emotion, right? Because in the brain, all of those areas are connected. So the thoughts will influence your pain signal. When people are catastrophizing, oh my gosh, this pain is killing me, pain goes up. And in fact, we've done studies where we can look at the intensity of pain based on people's attention. So when you put attention on it, the pain goes up. So thoughts can influence that. Mood, when you're sad, pain goes up. When you're happy and you're thinking about other stuff, you don't even think about your pain. So I'll have patients who say, I went out with my girlfriends, I was having a great time, nothing bothered me, until I came to the house and the dog has poop on the floor, and then, it triggered a stress response. So pain is always an output from the brain, and how that interpretation of that signal is based on what your life experiences have been. So if you've had a lot of trauma in your house, your nervous system is a little hyper, okay? If there is other things, stresses and going on, pain experience will become more magnified. And all of that is in the context of protection. It is to protect you. But then once pain goes on past 3 months, it becomes pathologic. That system is not working as well anymore. So now a small signal, basically, some way we look at that is, like a fire alarm that goes off when you walk past it, even if there's no smoke, right? So people create all this pain experience with something that it shouldn't cause this much pain. So we can do MRIs, we can do this stuff, we can do biomarkers. We don't see anything there, and there is still pain. So this is where we have to work on the brain. And the question of, how do we do that? So one of that mechanism is neuroplasticity, where the brain changes that signal. And there's new therapies called pain reprocessing therapy. We can get into some of those things. And that is able to help people solve the pain. CBT, some of these other affective therapies that we have are all able to reverse it. And we can even document on imaging where we can see in the state of people that have chronic pain, fibromyalgia, there's even shrinkage in the brain. And once you treat that with this affective therapies, the brain actually changes. So the brain is so powerful in modulating pain. And I think it's important for individuals who have chronic pain to really understand this. And one of the problems that we have with current issue with treating pain is that we are using a medical model, a biomedical model, to address a problem that requires a biopsychosocial model. So that's the issue.
So this is actually, you've kind of linked something here for me. You mentioned that pain is a protective tool. The body is trying to protect from some sort of challenge or some sort of stressor that could be problematic for survival or for whatnot. It sounds very much like it's a protective mechanism from when we feel unsafe.
Absolutely. Yes.
Right? Safety being this huge piece to the puzzle, psychological safety. If anybody out there has not yet heard of the polyvagal theory and the idea of safety being the driver of autonomic control of vagus nerve activation, it sounds very much like safety plays a huge piece to the puzzle here in the perception of pain and the production of these pain feelings, right? So just like you mentioned, when a person goes out with their girlfriends, out to dinner, has so much fun, doesn't experience the pain that they normally are feeling. But then as soon as the emotion of there's poop on the ground because the dog pooped at home, and we're out of this feeling of comfort and safety and happiness and joy, that shift in feelings is actually what's triggering the perception of that pain response. So safety seems like it's a really important piece to this puzzle. Can you speak to that a little bit?
Yes, and that's actually the very thing you're talking about is the fundamental basis of pain reprocessing therapy. So trying to change the perception, the perceived threat, fear, okay? So pain is basically a signal plus fear, okay? So when you take away the fear, the pain is not, you nullify the pain, okay? So really when people have had chronic pain, there's this fear, the safety component that you talk about, because the safety component will keep pushing up specific astrocyte and microglia to become like hyperactive, and the whole nervous system is activated. So the whole idea of even getting people to change the brain to change is based on this theory of let's change the perceived threat, that the pain is you're safe, right? So when they do this therapy with individuals that are trying to get them out of this pain state, they tell them to feel safe in your body. So you do somatic tracking where you're just going to feel like, I am safe. So saying that I'm safe alone brings pain down. So it's really, really a huge part of that whole component. And then once people can get it, because once people have had injuries with back pain or whatever, they're afraid to bend down, right? Because of that fear is there, even when they're thinking about it, that corresponding chemistry is created. Muscles tense up, cortisol is pushing and everything else. So the brain with fear, so it's all about safety. And people that are not safe within themselves, it's difficult to get rid of pain.
Let's divide that chronic pain into two pieces pain into two pieces, because I love the work by Clifford Wolf talking about adaptive pain and maladaptive pain. And adaptive pain is, you've got an initial painful incident. You stuck your finger with a pin or something like that. There's a reactive pain that says, hey, stop doing that. That's going to injure me right now. But then there's that longer term pain while you're healing that is also an adaptive pain, but it's designed to ache. It's designed to be there in the background to prevent you from using that limb or that digit or whatever while it's healing, because you might exacerbate that problem. So imagine you've injured your elbow. Well, the elbow, continues to hurt in order to prevent you from using your arm while it's healing, because it needs that healing time. And that is a slightly different pain, but it's oftentimes the type of pain that people who have chronic pain injuries are experiencing. They're not experiencing that reactive, pain coming from, sticking your finger with a fork, but it's something that's aching and it lasts for a long time. And so what are the differences, in the brain chemistry and the brain pathways associated with those two different types of pain? Because I would imagine the first one is actually trying to get you to move. There's probably some dopamine involved in there for motivating motion, but the longer term aching pain while you're healing to prevent you from re-injuring or doing more damage is something very different. Can you explain that for us?
Absolutely. So that's a great question. And so when it comes to the processing of pain itself, okay, so there's all of these things that are happening in the periphery, inflammation, neurogenic inflammation. The nerves have to keep firing to just so you can kind of pay attention to all of that. The neuroplasticity that I talked about, the epigenetic changes, all of those things are actually physiologic. They're supposed to be there. So the difference is that they don't turn off after 3 months, after 6 months, then they become pathologic. Okay.
That's the maladaptive part where they don't switch back.
The maladaptive part, because it is needed. It is needed. And it's still a protective mechanism. So you can't even, so that's why even when people undergo anesthesia and we can block things afterwards, they can feel the pain because the body is like, I still need to make you aware of things. Okay. So this wired protective system is there. And the issue with chronic pain is that it just never turns off. And the reason why it's not turning off in most cases, we talked about trauma, other things. Okay. It's also a function as the very things. It comes to the health of the cell. You have specific things in the gut that will influence the pain experience. You have cortisol that will influence the pain experience. Autonomic dysfunction will influence the pain experience. Hormones will influence the pain experience. Mitochondrial dysfunction will influence. So all of those things are things that need to be looked at when we are talking about chronic pain treatment. So in fact, when one of the things, we talk about neuroplasticity, and there's this therapy that helps very well with it. But when people are doing that and they're still eating junk and they're not sleeping well and they are not, they're not forgiving, it's hard for, so because it's hard to hack, I always say it's hard to hack your psychology than your physiology. So if we can optimize the physiology, things work a lot easier. But to your question, yes, that system is important. It needs to be there, but it just never turns off because you have all these other things that are perpetuating that pain process. And a simple way that I talk to my patient about this is to think about, the predisposing factor, the precipitating factor, and more importantly, the perpetuating factor. People understand what caused the pain. They remember, I fell on ice 10 years ago. They've had surgery. They've done this. They're still in pain, but they don't know what's keeping them in pain. What is perpetuating your pain is a function of your health. If you're not sleeping, pain is not going to get better.
You just connected a huge dot for me. And I love this saying that you have there, that it's easier to hack your physiology than it is to hack your psychology. And I think people need to understand that, we want to change our habits. We want to change our lifestyles. We want to live in a more healthy way and we want to have better habits and whatnot. But when we just try to hack the psychology piece and we forget about all of those fundamental physiological processes that need to be working optimally, it becomes so difficult to create real habit change. Versus if you do those foundational pieces really well, which is why you have those 4 rooms laid out in a very specific way, right? Number 1, meditation. Let's get your physiology, autonomic physiology shifted by teaching you to breathe in a more parasympathetic manner. Start getting those signals out to the cells to down-regulate any inflammatory processing, to turn down the hypersensitivity towards an activated microglial cell, right? Creating physiological shift with that, then going into sleep and going into nutrition and making sure that you're eating a whole foods clean diet and you're not constantly snacking in the middle of the night or whatever, right? And then optimizing your sleep. And I think those are so important to understand. So hacking physiology first and creating good, strong foundational pieces there then allows you to make those positive shifts from a psychological perspective and change those neurological tracks. I think that's so, so powerful.
For sure. And I was going to just add on to that, but the part of the reason why physiology is easier to hack than psychology is we know what to do physiologically.
Yes.
We've known this for 10,000 years. What we're saying here about sleep, good diet, and exercise,
everybody knows
honestly,
it.
I think they probably have cave paintings in France somewhere from 35,000 years ago that say this.
I'm sure.
But what we need to understand now, and it's really only in the modern era that we have the neuroscience to understand about neuroplasticity and understand, and this is one of the big learnings that I actually gained from, talking with Brody Miller when we had Dr. Miller on, was talking about the fact that neuroplasticity is almost like a metabolic function. It's something that you can hack if you know how to, simply by doing mental exercises that teach your brain that neuroplasticity doesn't have to be emotional. It doesn't have to be pain oriented in order to get your brain into the zone where it's capable of neuroplasticity. Think of it like a muscle. Being able to make those neuroplastic changes in the brain is something that you have to teach your brain how to do to a certain extent and become better at. And there are simple exercises that you can do, which he lays out in exhaustive detail to his credit, ways to do that are simple, easy. Most people don't do them. You're training your brain to do things differently than you would otherwise. I was talking about the fact that, if you're an athlete, if you take a person who has never touched a basketball in his life, but he played soccer all of his life, and you compare how quickly that person is going to pick up the game of basketball versus a person who's never played any sports and plays chess all the time, not that there's anything wrong with chess, but at the end of the day, the athlete is going to pick it up faster. And the reason is because the parts of the brain where that neuroplasticity needs to happen, they're already used to that. It's already used to making those changes. So if you get your brain used to making changes, then you're going to be able to heal. And I think one of the things that I've seen in dealing with people who have not just chronic pain, but other chronic ailments, and we're going to get into that too, because I think there's a whole sick program that runs beyond pain into other symptoms, is that you find people who are intellectually and emotionally rigid, oftentimes the people who are more susceptible to not being able to get out of this chronic pain cycle. And so being mentally flexible, being emotionally flexible leads to physically being able to get out of that pain state more quickly.
Absolutely. And in fact, one of the whole principle, behind neuroplasticity and pain treatment is that you're trying to unlearn the pain. It's unlearning the old habits, right? You get up in the morning, the first thing they go to is like, this knee pain. They're looking for it. The brain is looking for it, and it's there. Okay. So I'll tell my patients, when you get up in the morning, try to focus on your right side. Even if the pain is on the left side, just focus on the sensation on the right side to get the brain not to be going there. So it's tough. And we even know, and it's, documented, people that have specific personality types are hard to get out of chronic pain because they want to control, they want to do all of that. But it's surrounding, it's relaxing and giving control and getting the brain to unlearn those bad habits. And that's hard to do, but it can be done. And this is where you can have different states of consciousness that make it easy to be able to kind of change the brain. So there's all these techniques and things that we can use to help people with that.
For sure. And I just to sort of now, I've hinted at it a couple of times, let's go there, which is it's not always pain. It can be symptoms. And I always talk about the fact that when you have the flu, you have a whole spectrum of symptoms that aren't necessarily related to your respiratory tract, but you're still experiencing them. And you will have those same symptoms, whether it's the flu or it's any one of a number of different infections that can affect various different parts of your body. Your brain, when it feels that, when it senses that inflammation present, and it does that through the autonomic nervous system as well, it's sensing inflammation. When that message comes up to the brain, if it's strong enough, the brain activates its sick program, much the same way it reactivates its pain program. It reacts with all of the symptoms, and those symptoms seem to be physiological, but they're really not. They're being centered in the brain. And those symptoms, just the same way you can end up in chronic pain, you can end up with these chronic symptoms. And that is really unfortunate because even though we're used to seeing those symptoms, I talk about the patient who comes into the office and says, my stomach hurts, my back hurts, I'm achy all over, I've got a headache, I'm feeling down. And the doctor says, well, you probably have the flu. Let's do a flu test. And the patient says, no, I've had these symptoms for 5 years. What does the doctor want to do? He wants to pick up a wooden cross, a little holy water, and back out of the room because he has no idea how to deal with this.
Yeah.
But it's exactly the same thing that you're talking about with chronic pain. It's chronic symptoms. And how do we undo them? We have to undo what's happened in the brain that has created that perception, which is incorrect. And you need all of the things you've been talking about. You need the distraction. You need to put the person in a safe place. You need to have that person begin neuroplasticity training. You need them to do all of those things, and you can undo that sick program being stuck on.
Yep. Well put. And then it's also, so the very things, and I'm sure Dr. Habib, you can even talk about this, about the whole autonomic system and the vagus nerve and everything else. So the body have all these nerves. The central nervous system is what makes us aware of things, right? So specifically when it comes to pain, it's just this specific type of nerve, C fibers. There is A beta, and all kind of different type of things that are sensing how things go wrong within our physiology. Okay. And then all of that also, to the very point, all converge in the brain, and the brain kind of lends it, and it becomes really trying to work backwards to understand the source of it, and then also work from the top. So it's always the top approach and the bottom approach. Let's figure out what's going on here. Let's solve the gut, right? Because even when we are solving the gut and the gut dysbiosis is resolved, the brain has not turned off that whole signal piece yet, and that would take some time. Okay. So it's always important for people to understand that we need to figure out what's going on in the periphery, and we also need to figure out what's going on centrally, because those two talk to each other, and you have to put that together to be able to get people to heal.
I would love for you to talk a little bit about these strategies that you've mentioned earlier in regards to helping to shift neuroplasticity away from patterns of chronic pain or patterns of emotional dysregulation leading to chronic pain. You mentioned a couple of them earlier. How are you using them in practice, and explain kind of the theory behind how they work?
Yeah, so pain reprocessing therapy is a therapy that has been validated specifically for pain, and I like it. I mean, we can do CBT, we can do other type of neuroaffective therapies. They all but the whole idea and the science behind pain reprocessing therapy is changing the perceived threat, that whole fear and security thing that you talked about. So it's really getting people to feel comfortable in their skin, to feel safe. The pain is there. The pain is there to protect you. Okay. People feel pain. What's going on? Do I have cancer? Do I have this? The brain, if you don't give meaning to the pain, the brain is going to try to look around to find the worst thing possible, right? People come in and they have a little bit of pain and they think something is so wrong. And it's because they didn't sleep well, or because they ate something that's influencing all of those things. So it's really getting people to be able to feel safe in their body, to connect with that. I don't do those work myself, because of, my time and things like that. So I will give people an app. It's called Curable. And Curable is an app that gives you a neuroscience education. So breathing and meditating and taking a sense of what's going on, becoming aware of the things that actually influence the pain. Because a lot of times patients don't know what's keeping them in pain, or they may not be open to the idea that this unforgiveness or this trauma or this thing that has happened that they don't want to deal with is keeping the nervous system so hyperactive that a small signal coming in still is perceived as a big pain experience.
I think a really important takeaway, and I'm just going to try to connect a couple of dots here. You've mentioned how we have to relabel a few things here, and relabel the idea that pain is not necessarily a bad thing.
Yes, it's not.
Right? Yeah. Inflammation is not necessarily a bad thing. In an acute circumstance, it's a required tool. The sympathetic nervous system, the fight or flight response, is not a bad thing. Innately, these are important pieces to creating an optimally functioning person, going back to the idea of optimal function. But if we've labeled it in our mind as being something that's bad, then what we've done is we've said, oh no, I'm in pain. This is bad. And the emotion that you've then attached to that is increasing the perception of that pain. And so it's so important, I think, to relabel that idea. And it sounds like that's exactly what pain reprocessing therapy is trying to do, is to actually put a label on it to say that the pain is actually doing you a favor initially, especially in an acute circumstance. Now, if you're experiencing challenging chronic pain, it can be very difficult to believe that the pain is a good thing. But it's actually trying to teach you something. It's actually trying to create a new habitual response. And if you start to understand that, then it can be a little bit easier to take away the emotional aspect behind it and be able to step back. And so I think from a practical standpoint, this sounds like a really wonderful therapy.
Absolutely. And it's the whole idea of kind of looking at the pain and just taking away the fear. Okay? Don't judge it. Why does it hurt? It's there. And this is called somatic tracking, where you can just sit there, something hurts. And if you sit there and play with it a little bit, I know this is hard when you're in chronic pain and the brain is just like, this hurts, something is wrong. But if people can relax, and you can change the experience of the pain, you can feel it It's there, but it doesn't have any meaning. It's a sensation. So we don't call it this, something is wrong or this crazy pain. It's a sensation, okay? And we even try to get our patients to say, it's a flare up, it's a drawback, giving a different meaning, because the words that we use about pain also influence pain. As you talk about the emotion is there. So any words that you use that are like emotionally fearful or triggering, and any of those things can make the pain experience worse. So it's really mastering the emotion and then being able to sit and look at it as a sensation. Oh, that's all it is. It is a sensation plus fear. So if you take it away the fear, it is a sensation. But obviously, there's places where there's significant pathology that things are just going to be running around and we have to kind of solve that. But for most people in chronic pain, if they can get to the healthy side of things, then it becomes, taking away the fear.
I love that. What about, you mentioned cognitive behavioral therapy, CBT therapies. I imagine there's some overlap in terms of what it's trying to do, but it sounds very much like let's pull towards more of an objective view of what's actually happening, step away from it affecting you as a subject in those moments and start to look at it in a more objective manner. Is that kind of the idea behind CBT as well?
Absolutely. And CBT is more about, again, the cognitive component of it. So the thoughts. What kind of thoughts are you having about this pain? This pain is killing me. This is horrible. This is miserable. So all of that actually keeps the loop going. Okay. And the very thing you also talked about that I think is important is like pain has different meanings. A lot of times pain is there in even different cultures. Pain is a way for us to grow, right? We grow through pain, and other things like that. Not saying that, somebody have pain is there to make you grow. But in most of us, there's people that I've seen where they're very busy executives, they're working all the time, they have all this stress, they're not paying attention. And then one day they went down to pick a piece of paper, their back locked out. And all of this time, their body is telling them, you got to pause, you got to listen, you got to do. So there's always things that we need to, as they say, the body keeps score. So if people have all these repetitive things that are going on in their life and they're not paying attention to, eventually your body is going to say, you know what, I'm in charge and I'm going to make you aware. And pain can manifest, multiple psychological stresses and other things can manifest as pain. And it can manifest as even limb paralysis, right? We can have people that can have, this functional, whatever neurological issues that we talk about. But a lot of times it's all influenced by stress. People can have stressful events that will trigger autoimmune disease where they can't even move anymore. So it's really a way for us to pay attention to something, whether it's physiologic, whether it's psychological, whether it's personal, whether it's societal, and all of those signals have to be dialed in to be able to understand where we are and where we have to move from there.
Yeah, the immune system, we talk about this a lot. The immune system and the autonomic nervous system do not distinguish between injury, physical injury. I always joke about it doesn't know the difference between being chased by a lion and being chased by a boss.
Yes.
I mean, a deadline is just as stressful as the risk of death. I mean, it's, the two will trigger your autonomic nervous system into a sympathetic fight or flight state. And all of the physiological things that come along with that are going to be triggered, even if you're sitting in the safety of your cubicle in the office. It's still going to happen. So we have to be aware of that and understand, as you said, the long-term effects. At some point, your body is going to say, enough, stop, don't do this anymore. We in the extreme, we see this in, the banking sector in Japan, where people are, dropping dead at their desks. They're culturally, pushed to stay in that stressed state for so long that it actually does kill them.
I'd love to shift gears a little bit and not to understate how important the psychology aspect of this is, but I'd love to shift gears into more of the physiology, some of the potential underlying things at a cellular level that can cause some of these pain experiences to become worse. You spoke at the Integrative Healthcare Symposium just this past weekend in New York on senolytics and cellular senescence. Talk a little bit about what cellular senescence is. Let's give our listeners a little bit of a background on what that means and how it can contribute to pain and chronic pain experience.
Absolutely. So cellular senescence. So senescence, if your audience are familiar with senescence, maybe they've heard of it in the context of the zombie cells. People, I think David Sinclair or whoever talks about it like the zombie cells. So basically, it's a fate of a cell. So your cells is dividing, and if something is going on as a stressful event, the cell will stop dividing to either control itself, kill itself, or it can become senescent cell where it's not dead, it's not alive. And then it creates all of this SAPs, something we call senescence associatory secretory phenotype, SAPs. Basically, it creates this poison that affects other cells around it, and it can create a lot of problems, okay? So there's some benefit to senescence because, in fact, that's how your body get rid of cancer cells. If your cell is dividing so quick, there is systems in there that just turns on and stop the cell from dividing, and it stops it from going anywhere else, and then your immune cells can come in and clear it. And senescence have actually been found to underlie multiple age-related disease. So when we talk about the hallmarks of aging, one of the reasons why we age because the cell age, and one of those is senescence. And when it comes to pain itself, osteoarthritis, low back pain, other multiple age-related type pain conditions, osteopenia, sarcopenia, all of that is actually influenced by senescence. Okay, so we have senescent cells, senescent cells in the knee, chondrocytes, knee cells, cartilage cells that will become senescent. They stop dividing because of stress and impact, and that can happen because somebody's an athlete, they run a lot, so we can actually see senescence in there. It can also happen because people are aging, and when that happens, you have all this inflammatory cascades of event, the SAPs, that will then create more damage to the environment of where the cells are. So when we're talking about pain management, and in my context, trying to understand a healthy way to understand or treat pain, we have to kind of look at this mechanism because it's the same mechanism that influence atherosclerosis, okay? So a simple way to even understand this concept is that the same concept, the same cellular processes, cellular senescence that's driving osteoarthritis or spine problems is the same problem that's going to cause atherosclerosis, is the same problem that's going to cause dementia, is the same process that's going to cause metabolic disorder. This is happening in all the cells. So it really becomes important for us to kind of look at this concept. How do we solve this? And I have become interested in this because when you solve this, not only are you solving pain, but you're solving metabolic health. You're solving cardiovascular health. You're getting people to live longer. So senescence is a huge concept in the space of longevity. And it relates to the very thing. It's all connected. So mitochondrial dysfunction can trigger senescence, right? Other stresses, glucose, sugar can trigger senescence. Mitogens, DNA damage. So any perceived stress in the system can create senescence. And when a cell becomes senescent, it has different pathways that it can take. And it can also upregulate specific proteins that makes it resistant to dying. So even though the cell is poisoning all the cells around them, they themselves are not dying. And the reason why they're not dying is that they have some proteins that are survival proteins that they've upregulated. And in fact, when we're using senolytics, we go after those type of proteins to get the cell to die. So I know I kind of talk a little bit all over the place, but hopefully it makes sense for your audience.
Let me just dig a little deeper on that, because my understanding of senescence, and I'm actually talking this weekend in part about that, is yes, it's true. It's one of the ways that the cell itself prevents cancer from progressing into an uncontrolled growth state is it stops cell division. It puts out it's secreting inflammatory markers in that SAPS state. It's also disabling apoptosis. And that's the way the cell normally, once internally it senses that things have gone awry, along the lines of what we're talking about, the cell will commit suicide. And there's a programmed cell death that gets triggered. But one of the really important components of that is your mitochondrial function. If your mitochondria become dysfunctional, the cell can't undergo apoptosis. So the zombie cell is really a consequence of sort of two things happening simultaneously. One is that the cells sustain some level of damage, whether it be epigenetic drift, loss of proteostasis, whatever, telomere attrition, et cetera, that the cell has ceased to function properly. And the normal way that it dies as a function of that is through this programmed cell death that the mitochondria are triggering, caspase pathways, et cetera. But it can't because the mitochondria are broken and they're dysfunctional. So I think of mitochondrial dysfunction as being, I don't want to say more important than, because that's not the right way of saying it, but it's sort of it's a required precursor, a required predicate for senescence and this SAS phenotype to exist. Is that correct? Is that the way you think of it? Or do you think that there is another pathway to senescence that doesn't involve mitochondria at all?
Absolutely. So the mitochondria, so there's midas, mitochondria induce senescence. So mitochondria damage is a huge part of creating senescence. There is also replicative senescence, where like in the case of cancer, okay? And then the other thing too is senescence actually occur across the lifespan. So even, in the oocytes, in a mom who is older, there is senescent cells that are actually implicating the eggs before the baby was even implanted to create like a kid with Down syndrome or something like that, okay? We also know that even senescence also plays a part in the placenta. For the baby to get pushed out of the womb, all this SAPs is what allowing that to happen. So it has better things. So it's something that occurs across the lifespan. So it's really hard to quantify it if it's bad or good, because it has a place in good and it has a place in bad. And it all becomes how much senescence accumulation versus how much the immune cells can clear those senescence. And the immune cells to be able to clear those senescence is a function of energy, mitochondria. So kind of looping it up, but there is different things that can trigger senescence.
And cancer
That's exactly.
cells, I was just going to say cancer cells have dysfunctional mitochondria. I mean,
exactly.
So it comes down to, interestingly, the function of the mitochondria, but on the immune cell side, because I want to ask, immune metabolism, immune cell functionality plays a huge role here, because where immune cells are dysfunctional, they're no longer capable of performing autophagy. And I think that's an important piece here. What is the autophagy role, the role of autophagy in clearing senescent cells? If immune cells are functional versus dysfunctional, is there an issue? What else could be going on there? Like, are there strategies that we can implement to ensure that the immune cells remain more capable and that we don't go over the threshold of the amount of senescence that's occurring locally within a tissue that can be cleared out? Is there something we can do there?
Yeah, so there's a couple, lifestyle interventions. I mean, again, if we're talking about things that are practical, we take it up that level and we can go back to the cellular pathways. We know there's certain things that actually help get rid of senescence. So caloric restrictions have been shown to be a senolytic. It will get rid of senescent cells, right? Because when you do that, you improve metabolism.
I was trying to lead you towards fasting, so that makes sense. I was leading you towards fasting, so this made a lot of sense.
Fasting, yes. Caloric restriction, intermittent fasting, exercise can get rid of senescence. So there's all these other lifestyle things that we can do that will help. But yes, it's a function of this imbalance between the immune system. So in fact, some of the therapies that are even being developed from a pharmaceutical standpoint is trying to look at, things that helps with immune cells to become more powerful to get rid of senescence. I mean, there's some trials that are going on, but the issue is that, as we know, senescence is also there to stop a cancer cell. So you don't want to take all the senescence out. So when you put a vaccine, they've developed all of these things to create a vaccine that may, create an immune cells and target all of that. It becomes a little tricky. So definitely anything that optimizes immune health, it helps. And then the other thing that we know through this whole neuroscience space of, aging is that all those hallmarks of aging are connected to each other. So if you can improve one aspect of it, it's called the unitary theory, where we know that if you can improve mitochondrial health, you can improve senescence, you can improve proteostasis, you can improve, microbiome dysfunction and all of these things. So they are all connected. So any lifestyle intervention that helps to optimize any of those hallmarks, specifically relating to energy and immune metabolism, it's all about energy. So metabolism, I'm actually really getting into it now because it's all about how efficiently the cell can use energy to take care of itself. And if there's problems there, then we have issues. So there is that. And then there is also, we talk about senolytic specific compounds that can be used, and we can talk about some of those things, fisetin, quercetin, dasatinib. And the importance of these compounds is that, and to the very thing that JP, you were talking about, there's different pathways. So the cell doesn't have only one pathway to prevent apoptosis from happening. There's 10 different pathways, and they're called senescence-associated anti-apoptotic pathways. So there's some in the mitochondria. So in the mitochondria, you have the BCL2 families. In the outside of the cell, you have tyrosine kinase, and this is where the fisetin and all of those things works. And even in the nucleus itself, you have P53, right? So that we can use a peptide called FOXO-DR that binds to it, unlocks it, and the cell can die. So there's all of these redundancies in all of these pathways for the cell to survive. So if you want to solve senescence, you can't just use one thing. Sometimes you have to use multiple things to kind of get the cell to there. So I don't know if I answered your question. I think I kind of lost my train of thought here. But the point is that there is lifestyle things that people can do. There is supplements that can help, senolytics, or we can also use something called senomorphics, so that the zombie cell can create pro-inflammatory chemistry that we can block. So we can choose not to kill the cell, which is senolytic, or we can just block the output, that inflammatory chemistry that's coming out. We also have peptides that we can use.
Yeah, or the shift the cell back to the point where it can kill itself.
It can kill itself, exactly. It becomes vulnerable. So we can also use peptides. We can use other type of therapies to address senescence. So an evolving field, but I'm very interested in how this, because once we figure that out, then it will be helpful to solve pain while solving longevity, which is what I'm very much interested in.
Well, I think by the time this podcast actually gets released, I will have already given my talk. So I'm not stealing my own thunder by saying this, but the work that, I've been working with a group of other people, colleagues, on for the better part of a year is demonstrating that unified theory actually brings those hallmarks of aging under one control system, which is your autonomic nervous system. And if you look, chronic sympathetic activation accelerates every single one of the hallmarks. And parasympathetic activity slows down or even reverses. And when we're doing work right now with vagus nerve stimulation, which is the direct activator of the parasympathetic, showing that those hallmarks slow down, or in the case of some like mitochondrial dysfunction and telomere attrition, can actually reverse. And so we're pretty excited about the idea that the current list of 12, there's a 13th, and the 13th one sits right at the center. It's sort of like, it's the one that controls the pace of all of the others. And it goes back to the same way you're treating, chronic pain with behavioral therapy and other therapies that are designed to enhance neuroplasticity. Well, even at the cellular level, we need that.
Absolutely. And there is immunosenescence, there's astrocyte senescence, there's microglia senescence. They're not working as well. So if we can optimize all of those things through healthy interventions, we get better results with not just pain, but overall health as well.
I've recently become stuck on this idea of the fact that life occurs in cycles, right? That we have cycle of parasympathetic, sympathetic activation, that we have cycles of feast and famine, that we have cycles of movement and recovery. We have cycles of being on and being off. And I think it's really important to understand that the way that our lifestyles have become is we tend to be stuck in one area for too long and not allow these cycles to flow in an optimized manner, affecting thus optimal function, right? We're living in a world where we're pushed to be in sympathetic stress mode a lot more of the time than we should be. We're pushed to be in feast mode, taking in as many calories as possible because there's new ads for the new combination. I don't know somebody posted this. There's Oreos that are Coke flavored now. Like, tell me that that's not real. Like, how is this happening? But we're pushed to be in feast mode, and famine or fasting is actually negative, right? Or at least that's the perception that it is. We're not giving ourselves moments of caloric restriction, of downtime, of giving our bodies a break from the digestive inputs. We're not giving ourselves a moment to pause from our phones all the time or from the screens that we're on all the time. And I think it's so important to note that we need to flow within the natural rhythm. And I think each of us needs to find what our natural rhythm is and really work to optimize that, because that then will provide, and I'm going to go back to the beginning point here, that health is optimal function. And function happens in these cycles. I realize I'm going a little philosophical here, but I think the idea here is chronic pain, as it sounds like it's coming from you, has a lot to do with the lack of these cycles being optimized and being stuck and creating these physiological and psychological mechanisms that push us out of these optimal cycles. I'd love for you to kind of give some final thoughts on what chronic pain therapy looks like going forward, and what are some of the basic tools that people should identify and work on right off the bat to improve how they experience pain?
Absolutely. So thank you for that and for bringing that balance out. And one of the things that I've come to appreciate, and in this space, I'm relatively new here in the integrative space, is the intelligence of the cell. That the cell can adapt in a healthy way or downregulate in a negative way, provided the signal. And it's all about balance. Okay. So everybody's doing antioxidants. It's redox. There's reduction also needed. Parasympathetic, sympathetic. So this flow thing is actually, that's nature, and that's actually what's going on within our physiology. Specifically, when it comes to pain, what I want people to take away from this is that pain is a sensory and emotional experience associated with potential tissue damage or no tissue damage. Okay. So you don't always have to have a tissue damage to have pain, because individuals will say, well, they look at my MRI, there's nothing there. Why am I in so much pain? And in fact, you go to doctors and they go, we don't see anything on your MRI, so you're making this up. Okay. So they don't understand pain. Pain can exist in the absence of tissue damage. So when you have pain and we don't see anything on your MRI, we don't see anything else, there's other things that are going on. Okay. Because when it comes to chronic pain, even at the cellular level itself, there is neuroinflammation, there is epigenetic changes, there is neuroplasticity, there is neurotransmitter imbalances. The signal going to the brain, GABA, substance P, they go up. Your body have a way to decrease that with other type of signals. That system become dysregulated. So there's all of these cellular processes that are going on that influence the state of chronic pain. And pain, first of all, need to be recognized as a protective mechanism. So when we have chronic pain, this means that protective mechanism has become maladaptive or has become pathologic. And the reason why it's become pathologic could be multiple reasons. And one that we didn't talk about, so some individuals with chronic pain, there is some genetic predisposition, and it all relates to kind of how the pain signal, something to do with sodium channel. So there's individuals who have that. And in fact, talking about the protectiveness of pain, there is persons who are born with congenital insensitivity to pain, where they can't sense pain. Those people don't live long. They die very soon because they can't feel, they step on things. So actually pain is needed to make you live longer.
There's a movie. Yeah. There's a movie coming out called Novocaine.
Yeah.
Novocaine, okay. That's right.
All about somebody who has no, and it reminds me, there was I think a book called there was The Girl Who Kicked the Bee's Nest. There was 3 books out of Scandinavia, but the villain in it was the woman's stepbrother who had exactly that same condition, couldn't feel any pain.
Yes.
And it's deadly.
Yep. So pain actually saves us. And then pain can also take away the quality of life and the quantity of life. Okay. So chronic pain, we don't want it, but there's ways to address pain. And it has to be starting with the very things we all been talking about, the fundamental. We have to look into your gut. What you're eating plays a part in your pain. And you can do your own little experiment. People wake up in the morning and go, my hands are stiff and I don't know what happened. Deconstruct in the last 48 hours. What did you do? What stresses? All of that. Stress will influence your pain. Exercise, sleep. So really fundamentally, if people can get those things right, it helps. And then it's also important for people to understand pain. So chronic pain education or pain education is now recognized as a form of treatment. So you need to understand what pain is. It's such a subjective experience. So even as a doctor, you come to me and you tell me about your pain, I can only imagine it. I'm not exactly sure what you're explaining to me. So since it's a subjective experience, only the subject can actually get themselves out of the pain. Okay, so I'll always tell my patients, I can do 30%, you have to do the 70% because you know that you can connect to that. Okay, so there are solutions, working on the brain, working on overall health. And then also the other thing I also want to push out is that there is always biomechanical deficit when we have chronic pain. Because when the pain signal is a sensory signal that goes up to the brain, there is corresponding motor nerve that comes in and inhibit muscles or whatever it is. So when you have pain and it's chronic, even when we're doing the medications, the supplement, everything else, we also need to strengthen muscles. So you have to do the chiropractic care. You have to do the physical therapy. You have to put all of those things together. And I guess the last thing I would say is also kind of looking at how we solve pain from a healthy way, from not just blocking pain signal. If I give you ibuprofen, I'm just blocking a pathway that's actually allowing you to heal the whole inflammatory cascade. We have to work on senescence in pain. We have to work on mitochondrial dysfunction in pain, in migraines. There's all of these energy imbalances that creates that. All of that is important. So microbiome, everything else that we talk about that influence health actually will make pain a lot better. And when you do all of those things, then all the other interventions that we do, the chiropractic care, the physical therapy, the acupuncture, the energy medicine, the medications, the surgeries, all of those things have better outcomes when people are healthy. And I want people that are out there struggling with chronic pain, that there are solutions, and it will take some work. It may not be from the conventional ways of, gabapentin, opioid, this and that, but we have to go beyond that. When we make you healthy, even those medicines will work a lot better when you're healthy.
And you'll need less of it.
Yes. And you're not even going to need it because obviously, those things are actually implicating, in fact, opioid can actually trigger senescence. Okay. And also decrease the hallmarks of aging as well.
For sure.
Sir, you are speaking my language. I love this talk. I love this conversation. JP, any final thoughts?
No, he just succinctly wrapped it up. I think it's a great topic. I one of the reasons I got involved in vagus nerve stimulation is it does many of the things that you're talking about and assists in many of the things that you're suggesting. So to the extent that that's part of the program, I'm all for it.
Wonderful.
This has been wonderful. Where can people find out more about you, follow you on Instagram / wherever else? Shoot those out.
Yeah. So the name of my practice is Ether Medicine. So Ether is spelled AETHER, Ether. So the Ether, we can talk about the Ether sometime. But Ether Medicine is in Wayne, a suburb of Philadelphia. And we focus on cellular health as a way to solve pain, improve performance, and health span. And the whole idea is that, when you solve health, pain gets better. So, and health is a function of the cell if you want to take it to a different level. So that's what we do. People can follow us on Instagram. I do a lot of education there. So Ether Medicine. Our website is www.ethermedicine.com. Hopefully we can type it in here if people can understand my accent. And I'm open to connecting with individuals who are struggling or even providers out there, other people who want to connect and collaborate to kind of help do a great job of solving pain, because young people should not be taking their life because we can't solve pain in 2024, 2023, okay, in America.
I love it. Thank you so much for doing this, for joining us and sharing such brilliant insights, connecting many dots in my own head. This has been just a great conversation, and I hope that this can go out and help a lot of people, because chronic pain is affecting a lot of people out there. And so if you got to this point in the podcast, please share this episode with 1, 2, 3 people who you think could benefit from this information. Somebody who's experiencing chronic pain and needs a hand held to support them through this and understand that creating health will help them experience less pain. Thank you so much for joining us. We will catch you all on the next one.
Thank you for having me. Yes.